Dear colleagues, today I am presenting a very particular case of suspected placental teratoma in a patient during the 26th week of gestation. As you can see from these images, there is a mass with almost irregular margins, a highly heterogeneous ecotexture with hyperechoic areas inside developing within the placental mass and appearing poorly vascularized on Doppler, thus raising the diagnostic suspicion of a teratoma. It is a tumor of embryonic tissues that originates from pluripotent embryonic cells, composed of all three germ layers, ectoderm, mesoderm, and endoderm, in varying proportions. It is located in the placental area, usually between the amnion and chorion, along the fetal side of the placenta. This is an extremely rare condition with less than 50 cases documented within the medical literature as case reports. But in most of these instances, the prognosis and course of the condition are generally favorable and benign. From a diagnostic point of view, ultrasound reveals indeed a formation with a heterogeneous ecotexture with pearly whitish areas inside that represent the ectodermal component and calcifications, which appears to have little vascularization on Doppler and is usually not very large in size. In fact, it usually does not exceed a maximum diameter of 15 centimeters. The differential diagnosis should primarily be distinguished from placental chorioangioma, which is a distinct type of vascular placental formation. The twin reversed arterial perfusion sequence, that is, the cardiac twin sequence found in monochorionic twin pregnancies and a complete hydatidiform mole. In the case of the trap sequence, however, it involves a mass made up of an amorphous cardiac acephalic twin in a monochorionic twin pregnancy, which is supplied by a second umbilical cord originating from the same placental mass. This is different from a teratoma, where a single placenta with a single umbilical cord supplies a single viable fetus. Furthermore, in the acardiac acephalic twin, it is usually possible to distinguish between a cranial and a caudal end within the amorphous mass. The differential diagnosis with a chorangioma, on the other hand, is simplified by the extremely high vascularization of the mass. In other words, the chorangioma, since it is a tumor of vascular origin that also tends to have greater volumetric growth. In the case of a hydatidiform mole, on the other hand, it is a trophoblastic disease that causes degeneration of the chorionic villi, in which the embryo is usually not visible and which is characterized by a diffuse cystic appearance. In this case, the differential diagnosis with chorangioma was made easier precisely by the use of color Doppler. If you look closely at these ultrasound images, you can clearly see how this specific formation, which displays those distinct pearly and calcified areas inside, which is very typical of the internal ultrasound structure of a teratoma, is, however, quite poorly vascularized and is found to be present within the placenta, situated mainly along the fetal side of the organ. The maximum dimensions of the formation which have been measured here are about 33 by 23 millimeters. And subsequently, again with the help of Doppler, an attempt was made to assess the relationship between the teratoma and the cord insertion, also to rule out those complications, albeit rare, related to a partial sequestration of blood by the formation, which could then be associated with reduced fetal blood flow and a possible restriction of growth. Here we observed that in reality it is quite far, approximately 45 millimeters, from the cord insertion. The total amount of amniotic fluid is perfectly normal. And from these detailed images, we can also clearly see that the umbilical artery Doppler flow is also normal. The patient also underwent an MRI scan. Here we can observe the mass, and first of all, how its size is essentially consistent with what was detected in the previous ultrasound study, but above all, how its nature also appears remarkably heterogeneous in its composition here, which further supports the diagnostic hypothesis of a teratoma. Therefore, we were highly optimistic and encouraged with the patient, since this is a medical condition that in the vast majority of cases is associated with a very positive and favorable outcome. And so the management basically consists of conservative ultrasound follow-up sessions, which aims to carefully assess any possible growth of the mass, the total amount of amniotic fluid, fetal Doppler, which in this specific case we saw was within the normal range, and the continuous monitoring of fetal growth. Obviously, the patient was advised to have a histological examination of the placenta at the time of delivery, since this is what allows for a definitive diagnosis. And thank you for your attention.